Page 87. Part 2, Cardinal Manifestations and Presentation of Diseases. Section 1. Pain. Chapter 18. Pain, Pathophysiology and Management. The province of medicine is to preserve and restore health and to relieve suffering. Understanding pain is essential to both of these goals. Because pain is universally understood as a signal of disease, it is the most common symptom that brings a patient to a physician's attention. The function of the pain sensory system is to protect the body and maintain homeostasis. It does this by detecting, localizing, and identifying potential or actual tissue damaging processes. Because different diseases produce characteristic patterns of tissue damage, the quality, time course, and location of a patient's pain lend important diagnostic clues. It is the physician's responsibility to provide rapid and effective pain relief. The pain sensory system. Pain is an unpleasant sensation localized to a part of the body. It is often described in terms of a penetrating or tissue-destructive process, for example, stabbing, burning, twisting, tearing, squeezing, and/or of a bodily or emotional reaction, for example, terrifying, nauseating, sickening. Furthermore, any pain of moderate or higher intensity is accompanied by anxiety and the urge to escape or terminate the feeling. These properties illustrate the duality or pain. It is both sensation and emotion. When it is acute, pain is characteristically associated with behavioral arousal and a stress response consisting of increased blood pressure, heart rate, pupil diameter, and plasma cortisol levels. In addition, local muscle contraction, for example, limb flexion, abdominal wall rigidity, is often present. Peripheral mechanisms. The primary afferent nociceptor. A peripheral nerve consists of the axons of three different types of neurons: primary sensory afferents, motor neurons, and sympathetic postganglionic neurons, figure 18-1. The cell bodies of primary sensory afferents are located in the dorsal root ganglia within the vertebral foramina. The primary afferent axon has two branches, one projects centrally into the spinal cord and the other projects peripherally to innervate tissues. Primary afferents are classified by their diameter, degree of myelination, and conduction velocity. The largest diameter afferent fibers, A beta, respond maximally to light touch and/or moving stimuli. They are present primarily in nerves that innervate the skin. In normal individuals, the activity of these fibers does not produce pain. There are two other classes of primary afferent nerve fibers: the small diameter myelinated A delta, and the unmyelinated C axons, figure 18-1. These fibers are present in nerves to the skin and to deep somatic and visceral structures. Some tissues, such as the cornea, are innervated only by A delta and C fiber afferents. Most A delta and C fiber afferents respond maximally only to intense, painful stimuli and produce the subjective experience of pain when they are electrically stimulated. This defines them as primary afferent nociceptors, pain receptors. The ability to detect painful stimuli is completely abolished when conduction in A delta and C fiber axons is blocked. Individual primary afferent nociceptors can respond to several different types of noxious stimuli. For example, most nociceptors respond to heat, intense cold, intense mechanical distortion, such as a pinch, changes in pH, particularly in acidic environment, and application of chemical irritants including adenosine triphosphate, ATP, serotonin, bradykinin, and histamine. Sensitization. When intense, repeated, or prolonged stimuli are applied to damaged or inflamed tissues, the threshold for activating primary afferent nociceptors is lowered, and the frequency of firing is higher for all stimulus intensities. Inflammatory mediators such as bradykinin, nerve growth factor, some prostaglandins, and leukotrienes contribute to this process, which is called sensitization. Sensitization occurs at the level of the peripheral nerve terminal, peripheral sensitization, as well as at the level of the dorsal horn of the spinal cord, central sensitization. Peripheral sensitization occurs in damaged or inflamed tissues, when inflammatory mediators activate intracellular signal transduction in nociceptors, prompting an increase in the production, transport, and membrane insertion of chemically gated and voltage-gated ion channels. These changes increase the excitability of nociceptor terminals and lower their threshold for activation by mechanical, thermal, and chemical stimuli. Central sensitization occurs when activity, generated by nociceptors during inflammation, enhances the excitability of nerve cells in the dorsal horn of the spinal cord. Following injury and resultant sensitization, normally innocuous stimuli can produce pain, termed allodynia. Sensitization is a clinically important process that contributes to tenderness, soreness, and hyperalgesia, increased pain intensity in response to the same noxious stimulus. For example, moderate pressure causes severe pain. A striking example of sensitization is sunburned skin, in which severe pain can be produced by a gentle slap on the back or a warm shower. Sensitization is of particular importance for pain and tenderness in deep tissues. Viscera are normally relatively insensitive to noxious mechanical and thermal stimuli, although hollow viscera do generate significant discomfort when distended. In contrast, when affected by a disease process with an inflammatory component, deep structures such as joints or hollow viscera characteristically become exquisitely sensitive to mechanical stimulation. A large proportion of A, delta and C fibrofronts innervating viscera are completely insensitive in normal non-injured, non-inflamed tissue. That is, they cannot be activated by known mechanical or thermal stimuli and are not spontaneously active. However, in the presence of inflammatory mediators, these afferents become sensitive to mechanical stimuli. Such afferents have been termed silent nociceptors, and their characteristic properties may explain how, under pathologic conditions, the relatively insensitive deep structures can become the source of severe and debilitating pain and tenderness. Low pH, prostaglandins, leukotrienes, and other inflammatory mediators such as bradykinin play a significant role in sensitization. Nociceptor-induced inflammation. Primary afferent nociceptors also have a neuroeffector function. Most nociceptors contain polypeptide mediators that are released from their peripheral terminals when they are activated, figure 18.2. An example is substance P, an 11-amino acid peptide. Substance P is released from primary afferent nociceptors and has multiple biologic activities. It is a potent vasodilator, degranulates mast cells, is a chemoattractant for leukocytes, and increases the production and release of inflammatory mediators. Interestingly, depletion of substance P from joints reduces the severity of experimental arthritis. Primary afferent nociceptors are not simply passive messengers of threats to tissue injury but also play an active role in tissue protection through these neuroeffector functions. Central mechanisms. The spinal cord and referred pain. The axons of primary afferent nociceptors enter the spinal cord via the dorsal root. They terminate in the dorsal horn of the spinal gray matter, figure 18.3. The terminals of primary afferent axons contact spinal neurons that transmit the pain signal to brain sites involved in pain perception. When primary afferents are activated by noxious stimuli, they release neurotransmitters from their terminals that excite the spinal cord neurons. The major neurotransmitter released is glutamate, which rapidly excites dorsal horn neurons. Primary afferent nociceptor terminals also release peptides, including substance P and calcitonin gene-related peptide, which produce a slower and long-lasting excitation of the dorsal horn neurons. The axon of each primary afferent contacts many spinal neurons, and each spinal neuron receives convergent inputs from many primary afferents. The convergence of sensory inputs to a single spinal pain transmission neuron is of great importance because it underlies the phenomenon of referred pain. All spinal neurons that receive input from the viscera and deep musculoskeletal structures also receive input from the skin. The convergence patterns are determined by the spinal segment of the dorsal root ganglion that supplies the afferent innervation of a structure. For example, the efferents that supply the central diaphragm are derived from the third and fourth cervical dorsal root ganglia. Primary efferents with cell bodies in these same ganglia supply the skin of the shoulder and lower neck. Thus, sensory inputs from both the shoulder skin and the central diaphragm converge on pain transmission neurons in the third and fourth cervical spinal segments. Because of this convergence and the fact that the spinal neurons are most often activated by inputs from the skin, activity evoked in spinal neurons by input from deep structures is mislocalized by the patient to a place that roughly corresponds with the region of skin innervated by the same spinal segment. Thus, inflammation near the central diaphragm is often reported as shoulder discomfort. This spatial displacement of pain sensation from the site of the injury that produces it is known as referred pain. Ascending pathways for pain. A majority of spinal neurons contacted by primary afferent nociceptors send their axons to the contralateral thalamus. These axons form the contralateral spinothalamic tract, which lies in the anterolateral white matter of the spinal cord, the lateral edge of the medulla, and the lateral pons and midbrain. The spinothalamic pathway is crucial for pain sensation in humans. Interruption of this pathway produces permanent deficits in pain and temperature discrimination. Spinothalamic tract axons ascend to several regions of the thalamus. There is tremendous divergence of the pain signal from these thalamic sites to several distinct areas of the cerebral cortex that subserve different aspects of the pain experience. Figure 18.4. One of the thalamic projections is to the somatosensory cortex. This projection mediates the purely sensory aspects of pain, that is, its location, intensity, and quality. Other thalamic neurons project to cortical regions that are linked to emotional responses, such as the cingulate gyrus and other areas of the frontal lobes, including the insular cortex. These pathways to the frontal cortex subserve the affective or unpleasant emotional dimension of pain. This affective dimension of pain produces suffering and exerts potent control of behavior. Because of this dimension, fear is a constant companion of pain. As a consequence, injury or surgical lesions to areas of the frontal cortex activated by painful stimuli can diminish the emotional impact of pain while largely preserving the individual's ability to recognize noxious stimuli as painful. Pain modulation. The pain produced by injuries of similar magnitude is remarkably variable in different situations and in different individuals. For example, athletes have been known to sustain serious fractures with only minor pain, and Beecher's classic World War II survey revealed that many soldiers in battle were unbothered by injuries that would have produced agonizing pain in civilian patients. Furthermore, even the suggestion that a treatment will relieve pain can have a significant analgesic effect, the placebo effect. On the other hand, many patients find even minor injuries, such as venipuncture, frightening and unbearable, and the expectation of pain can induce pain even without a noxious stimulus. The suggestion that pain will worsen following administration of an inert substance can increase its perceived intensity, the nocebo effect. The powerful effect of expectation and other psychological variables on the perceived intensity of pain is explained by brain circuits that modulate the activity of the pain transmission pathways. One of these circuits has links to the hypothalamus, midbrain, and medulla, and it selectively controls spinal pain transmission neurons through a descending pathway. Figure 18.4. Human brain imaging studies have implicated this pain-modulating circuit in the pain-relieving effect of attention, suggestion, and opioid analgesic medications. Figure 18.5. Furthermore, each of the component structures of the pathway contains opioid receptors and is sensitive to the direct application of opioid drugs. In animals, lesions of this descending modulatory system reduce the analgesic effect of systemically administered opioids such as morphine. Along with the opioid receptor, The component nuclei of this pain-modulating circuit contain endogenous opioid peptides such as the enkephalins and beta-endorphin. The most reliable way to activate this endogenous opioid-mediated modulating system is by suggestion of pain relief or by intense emotion directed away from the pain-causing injury, for example, during severe threat or an athletic competition. In fact, pain-relieving endogenous opioids are released following surgical procedures and in patients given a placebo for pain relief. Pain-modulating circuits can enhance as well as suppress pain. Both pain-inhibiting and pain-facilitating neurons in the medulla project to and control spinal pain transmission neurons. Because pain transmission neurons can be activated by modulatory neurons, it is theoretically possible to generate a pain signal with no peripheral noxious stimulus. In fact, human functional imaging studies have demonstrated increased activity in this circuit during migraine headaches. A central circuit that facilitates pain could account for the finding that pain can be induced by suggestion or enhanced by expectation and provides a framework for understanding how psychological factors can contribute to chronic pain. Neuropathic pain. Lesions of the peripheral or central nociceptive pathways typically result in a loss or impairment of pain sensation. Paradoxically, damage to or dysfunction of these pathways can also produce pain. For example, damage to peripheral nerves, as occurs in diabetic neuropathy, or to primary efferents, as in herpes zoster infection, can result in pain that is referred to the body region innervated by the damaged nerves. Pain may also be produced by damage to the central nervous system, CNS, for example, in some patients following trauma or vascular injury to the spinal cord, brainstem, or thalamic areas that contain central nociceptive pathways. Such neuropathic pains are often severe and are typically resistant to standard treatments for pain. Neuropathic pain typically has an unusual burning, tingling, or electric shock-like quality and may be triggered by very light touch. These features are rare in other types of pain. On examination, a sensory deficit is characteristically present in the area of the patient's pain. Hyperpathia, a greatly exaggerated pain sensation to innocuous or mild nociceptive stimuli, is also characteristic of neuropathic pain. Patients often complain that the very lightest moving stimulus evokes exquisite pain, allodynia. In this regard, it is of clinical interest that a topical preparation of 5% lidocaine in patch form is effective for patients with post-herpetic neuralgia who have prominent allodynia. A variety of mechanisms contribute to neuropathic pain. As with sensitized primary afferent nociceptors, damaged primary efferents, including nociceptors, become highly sensitive to mechanical stimulation and may generate impulses in the absence of stimulation. Increased sensitivity and spontaneous activity are due, in part, to an increased concentration of sodium channels in the damaged nerve fiber. Damaged primary efferents may also develop sensitivity to norepinephrine. Interestingly, spinal cord pain transmission neurons cut off from their normal input may also become spontaneously active. Thus, both CNS and peripheral nervous system hyperactivity contribute to neuropathic pain. Sympathetically maintained pain. Patients with peripheral nerve injury occasionally develop spontaneous pain in the region innervated by the nerve. This pain is often described as having a burning quality. The pain typically begins after a delay of hours to days or even weeks and is accompanied by swelling of the extremity, periarticular bone loss, and arthritic changes in the distal joints. The pain may be relieved by a local anesthetic block of the sympathetic innervation to the affected extremity. Damaged primary afferent nociceptors acquire adrenergic sensitivity and can be activated by stimulation of the sympathetic outflow. This constellation of spontaneous pain and signs of sympathetic dysfunction following injury has been termed complex regional pain syndrome, CRPS. When this occurs after an identifiable nerve injury, it is termed complex regional pain syndrome type 2, also known as post-traumatic neuralgia or, if severe, causalgia. When a similar clinical picture appears without obvious nerve injury, it is termed complex regional pain syndrome type 1, also known as reflex sympathetic dystrophy. Complex regional pain syndrome can be produced by a variety of injuries, including fractures of bone, soft tissue trauma, myocardial infarction, and stroke. Chap. 446. Complex regional pain syndrome type 1 typically resolves with symptomatic treatment. However, when it persists, detailed examination often reveals evidence of peripheral nerve injury. Although the pathophysiology of complex regional pain syndrome is poorly understood, the pain and the signs of inflammation, when acute, can be rapidly relieved by blocking the sympathetic nervous system. This implies that sympathetic activity can activate undamaged nociceptors when inflammation is present. Signs of sympathetic hyperactivity should be sought in patients with post-traumatic pain and inflammation and no other obvious explanation. Treatment. Acute pain. The ideal treatment for any pain is to remove the cause. Thus, while treatment can be initiated immediately, efforts to establish the underlying etiology should always proceed as treatment begins. Sometimes, treating the underlying condition does not immediately relieve pain. Furthermore, some conditions are so painful that rapid and effective analgesia is essential, for example, the postoperative state, burns, trauma, cancer, or sickle cell crisis. Analgesic medications are a first line of treatment in these cases, and all practitioners should be familiar with their use. Aspirin, acetaminophen, and nonsteroidal anti-inflammatory agents, NSAIDs. These drugs are considered together because they are used for similar problems and may have a similar mechanism of action. Table 18.1. All these compounds inhibit cyclooxygenase, COX, and, except for acetaminophen, all have anti-inflammatory actions, especially at higher dosages. They are particularly effective for mild to moderate headache and for pain of musculoskeletal origin. Because they are effective for these common types of pain and are available without prescription, cyclooxygenase inhibitors are by far the most commonly used analgesics. They are absorbed well from the gastrointestinal tract and, with occasional use, have only minimal side effects. With chronic use, gastric irritation is a common side effect of aspirin and nonsteroidal anti-inflammatory drugs and is the problem that most frequently limits the dose that can be given. Gastric irritation is most severe with aspirin, which may cause erosion and ulceration of the gastric mucosa leading to bleeding or perforation. Because aspirin irreversibly acetylates platelet cyclooxygenase and thereby interferes with coagulation of the blood, gastrointestinal bleeding is a particular risk. Older age and history of gastrointestinal disease increase the risks of aspirin and nonsteroidal anti-inflammatory drugs. In addition to the well-known gastrointestinal toxicity of nonsteroidal anti-inflammatory drugs, nephrotoxicity is a significant problem for patients using these drugs on a chronic basis. Patients at risk for renal insufficiency, particularly those with significant contraction of their intravascular volume as occurs with chronic diuretic use or acute hypovolemia, should be monitored closely. Nonsteroidal anti-inflammatory drugs can also increase blood pressure in some individuals. Long-term treatment with nonsteroidal anti-inflammatory drugs requires regular blood pressure monitoring and treatment if necessary. Although toxic to the liver when taken in high doses, acetaminophen rarely produces gastric irritation and does not interfere with platelet function. The introduction of parenteral forms of nonsteroidal anti-inflammatory drugs, ketorolac and diclofenac, extends the usefulness of this class of compounds in the management of acute severe pain. Both agents are sufficiently potent and rapid in onset to supplant opioids for many patients with acute severe headache and musculoskeletal pain. There are two major classes of cyclooxygenase. Cyclooxygenase 1 is constitutively expressed, and cyclooxygenase 2 is induced in the inflammatory state. Cyclooxygenase 2 selective drugs have similar analgesic potency and produce less gastric irritation than the non-selective cyclooxygenase inhibitors. The use of cyclooxygenase 2 selective drugs does not appear to lower the risk of nephrotoxicity compared to non-selective nonsteroidal anti-inflammatory drugs. On the other hand, cyclooxygenase 2 selective drugs offer a significant benefit in the management of acute postoperative pain because they do not affect blood coagulation. Non-selective cyclooxygenase inhibitors are usually contraindicated postoperatively because they impair platelet-mediated blood clotting and are thus associated with increased bleeding at their operative site. Cyclooxygenase 2 inhibitors, including celecoxib, Celebrex, are associated with increased cardiovascular risk. It appears that this is a class effect of nonsteroidal anti-inflammatory drugs, excluding aspirin. These drugs are contraindicated in patients in the immediate period after coronary artery bypass surgery and should be used with caution in elderly patients and those with a history of or significant risk factors for cardiovascular disease. Opioid analgesics. Opioids are the most potent pain-relieving drugs currently available. Of all analgesics, they have the broadest range of efficacy and provide the most reliable and effective method for rapid pain relief. Although side effects are common, most are reversible. Nausea, vomiting, pruritus, and constipation are the most frequent and bothersome side effects. Respiratory depression is uncommon at standard analgesic doses, but can be life-threatening. Opioid-related side effects can be reversed rapidly with the narcotic antagonist naloxone. Many physicians, nurses, and patients have a certain trepidation about using opioids that is based on an exaggerated fear of addiction. In fact, there is a vanishingly small chance of patients becoming addicted to narcotics as a result of their appropriate medical use. The physician should not hesitate to use opioid analgesics in patients with acute severe pain. Table 18.1 lists the most commonly used opioid analgesics. Opioids produce analgesia by actions in the CNS. They activate pain inhibitory neurons and directly inhibit pain transmission neurons. Most of the commercially available opioid analgesics act at the same opioid receptor, neuroreceptor, differing mainly in potency, speed of onset, duration of action, and optimal route of administration. Some side effects are due to accumulation of non-opioid metabolites that are unique to individual drugs. One striking example of this is normeperidine, a metabolite of meperidine. At higher doses of meperidine, typically greater than 1 gram/d, accumulation of normeperidine can produce hyperexcitability and seizures that are not reversible with naloxone. Normeperidine accumulation is increased in patients with renal failure. The most rapid pain relief is obtained by intravenous administration of opioids. Relief with oral administration is significantly slower. Because of the potential for respiratory depression, patients with any form of respiratory compromise must be kept under close observation following opioid administration. An oxygen saturation monitor may be useful, but only in a setting where the monitor is under constant surveillance. Opioid-induced respiratory depression is typically accompanied by sedation and a reduction in respiratory rate. A fall in oxygen saturation represents a critical level of respiratory depression and the need for immediate intervention to prevent life-threatening hypoxemia. Ventilatory assistance should be maintained until the opioid-induced respiratory depression has resolved. The opioid antagonist naloxone should be readily available whenever opioids are used at high doses or in patients with compromised pulmonary function. Opioid effects are dose-related, and there is great variability among patients in the doses that relieve pain and produce side effects. Synergistic respiratory depression is common when opioids are administered with other CNS depressants, most commonly the benzodiazepines. Because of this, initiation of therapy requires titration to optimal dose and interval. The most important principle is to provide adequate pain relief. This requires determining whether the drug has adequately relieved the pain and frequent reassessment to determine the optimal interval for dosing. The most common error made by physicians in managing severe pain with opioids is to prescribe an inadequate dose. Because many patients are reluctant to complain, This practice leads to needless suffering. In the absence of sedation at the expected time of peak effect, a physician should not hesitate to repeat the initial dose to achieve satisfactory pain relief. An innovative approach to the problem of achieving adequate pain relief is the use of patient-controlled analgesia, PCA. Patient-controlled analgesia uses a microprocessor-controlled infusion device that can deliver a baseline continuous dose of an opioid drug as well as pre-programmed additional doses whenever the patient pushes a button. The patient can then titrate the dose to the optimal level. This approach is used most extensively for the management of postoperative pain, but there is no reason why it should not be used for any hospitalized patient with persistent severe pain. Patient-controlled analgesia is also used for short-term home care of patients with intractable pain, such as that caused by metastatic cancer. It is important to understand that the patient-controlled analgesia device delivers small, repeated doses to maintain pain relief. In patients with severe pain, the pain must first be brought under control with a loading dose before transitioning to the patient-controlled analgesia device. The bolus dose of the drug, typically 1 mg of morphine, 0.2 mg of hydromorphone, or 10 grams of fentanyl, can then be delivered repeatedly as needed. To prevent overdosing, patient-controlled analgesia devices are programmed with a lockout period after each demand dose is delivered, 5 to 10 minutes, and a limit on the total dose delivered per hour. Although some have advocated the use of a simultaneous continuous or basal infusion of the patient-controlled analgesia drug, this increases the risk of respiratory depression and has not been shown to increase the overall efficacy of the technique. The availability of new routes of administration has extended the usefulness of opioid analgesics. Most important is the availability of spinal administration. Opioids can be infused through a spinal catheter placed either intrathecally or epidurally. By applying opioids directly to the spinal or epidural space adjacent to the spinal cord, regional analgesia can be obtained using relatively low total doses. Indeed, the dose required to produce effective localized analgesia when using morphine intrathecally, 0.1 to 0.3 mg, is a fraction of that required to produce similar analgesia when administered intravenously, 5 to 10 mg. In this way, side effects such as sedation, nausea, and respiratory depression can be minimized. This approach has been used extensively during labor and delivery and for postoperative pain relief following surgical procedures. Continuous intrathecal delivery via implanted spinal drug delivery systems is now commonly used, particularly for the treatment of cancer-related pain that would require sedating doses for adequate pain control if given systemically. Opioids can also be given intranasally, butorphanol, rectally, and transdermally, fentanyl and buprenorphine, or through the oral mucosa, fentanyl, thus avoiding the discomfort of frequent injections in patients who cannot be given oral medication. The fentanyl and buprenorphine transdermal patches have the advantage of providing fairly steady plasma levels, which maximizes patient comfort. Recent additions to the armamentarium for treating opioid-induced side effects are the peripherally acting opioid antagonists salvimopan, Enterag, and methylnoltoxone, Relista. Alvimopan is available as an orally administered agent that is restricted to the intestinal lumen by limited absorption. Methylnoltoxone is available in a subcutaneously administered form that has virtually no penetration into the CNS. Both agents act by binding to peripheral mu receptors, thereby inhibiting or reversing the effects of opioids at these peripheral sites. The action of both agents is restricted to receptor sites outside of the CNS. Thus, these drugs can reverse the adverse effects of opioid analgesics that are mediated through their peripheral receptors without reversing their analgesic effects. Alvimopan has proven effective in lowering the duration of persistent ileus following abdominal surgery in patients receiving opioid analgesics for postoperative pain control. Methylnoltoxone has proven effective for relief of opioid-induced constipation in patients taking opioid analgesics on a chronic basis. Opioid and cyclooxygenase inhibitor combinations. When used in combination, opioids and cyclooxygenase inhibitors have additive effects. Because a lower dose of each can be used to achieve the same degree of pain relief and their side effects are non-additive, such combinations are used to lower the severity of dose-related side effects. However, fixed-ratio combinations of an opioid with acetaminophen carry an important risk. Dose escalation as a result of increased severity of pain or decreased opioid effect as a result of tolerance may lead to ingestion of levels of acetaminophen that are toxic to the liver. Although acetaminophen-related hepatotoxicity is uncommon, it remains a significant cause for liver failure. Thus, many practitioners have moved away from the use of opioid-acetaminophen combination analgesics to avoid the risk of excessive acetaminophen exposure as the dose of the analgesic is escalated. Chronic pain. Managing patients with chronic pain is intellectually and emotionally challenging. The patient's problem is often difficult or impossible to diagnose with certainty. Such patients are demanding of the physician's time and often appear emotionally distraught. The traditional medical approach of seeking an obscure organic pathology is usually unhelpful. On the other hand, psychological evaluation and behaviorally based treatment paradigms are frequently helpful, particularly in the setting of a multidisciplinary pain management center. Unfortunately, this approach, while effective, remains largely underused in current medical practice. There are several factors that can cause, perpetuate, or exacerbate chronic pain. First, of course, the patient may simply have a disease that is characteristically painful for which there is presently no cure. Arthritis, cancer, chronic daily headaches, fibromyalgia, and diabetic neuropathy are examples of this. Second, there may be secondary perpetuating factors that are initiated by disease and persist after that disease has resolved. Examples include damaged sensory nerves, sympathetic efferent activity, and painful reflex muscle contraction, spasm. Finally, a variety of psychological conditions can exacerbate or even cause pain. There are certain areas to which special attention should be paid in a patient's medical history. Because depression is the most common emotional disturbance in patients with chronic pain, patients should be questioned about their mood, appetite, sleep patterns, and daily activity. A simple standardized questionnaire, such as the Beck Depression Inventory, can be a useful screening device. It is important to remember that major depression is a common, treatable, and potentially fatal illness. Other clues that a significant emotional disturbance is contributing to a patient's chronic pain complaint include pain that occurs in multiple, unrelated sites, a pattern of recurrent, but separate, pain problems beginning in childhood or adolescence, pain beginning at a time of emotional trauma, such as the loss of a parent or spouse, a history of physical or sexual abuse, and past or present substance abuse. On examination, special attention should be paid to whether the patient guards the painful area and whether certain movements or postures are avoided because of pain. Discovering a mechanical component to the pain can be useful both diagnostically and therapeutically. Painful areas should be examined for deep tenderness, noting whether this is localized to muscle, ligamentous structures, or joints. Chronic myofascial pain is very common, and, in these patients, deep palpation may reveal highly localized trigger points that are firm bands or knots in muscle. Relief of the pain following injection of local anesthetic into these trigger points supports the diagnosis. A neuropathic component to the pain is indicated by evidence of nerve damage, such as sensory impairment, exquisitely sensitive skin, allodynia, weakness, and muscle atrophy, or loss of deep tendon reflexes. Evidence suggesting sympathetic nervous system involvement includes the presence of diffuse swelling, changes in skin color and temperature, and hypersensitive skin and joint tenderness compared with the normal side. Relief of the pain with a sympathetic block supports the diagnosis, but once the condition becomes chronic, the response to sympathetic blockade is of variable magnitude and duration. The role for repeated sympathetic blocks in the overall management of complex regional pain syndrome is not established. A guiding principle in evaluating patients with chronic pain is to assess both emotional and organic factors before initiating therapy. Addressing these issues together, rather than waiting to address emotional issues after organic causes of pain have been ruled out, improves compliance in part because it assures patients that a psychological evaluation does not mean that the physician is questioning the validity of their complaint. Even when an organic cause for a patient's pain can be found, it is still wise to look for other factors. For example, a cancer patient with painful bony metastasis may have additional pain due to nerve damage and may also be depressed. Optimal therapy requires that each of these factors be looked for and treated. Treatment. Chronic pain. Once the evaluation process has been completed and the likely causative and exacerbating factors identified, an explicit treatment plan should be developed. An important part of this process is to identify specific and realistic functional goals for therapy, such as getting a good night's sleep, being able to go shopping, or returning to work. A multidisciplinary approach that uses medications, counseling, physical therapy, nerve blocks, and even surgery may be required to improve the patient's quality of life. There are also some newer, relatively invasive procedures that can be helpful for some patients with intractable pain. These include image-guided interventions such as epidural injection of glucocorticoids for acute radicular pain and radiofrequency treatment of the facet joints for chronic facet-related back and neck pain. For patients with severe and persistent pain that is unresponsive to more conservative treatment, placement of electrodes within the spinal canal overlying the dorsal columns of the spinal cord stimulation, or implantation of intrathecal drug delivery systems has shown significant benefit. The criteria for predicting which patients will respond to these procedures continue to evolve. They are generally reserved for patients who have not responded to conventional pharmacologic approaches. Referral to a multidisciplinary pain clinic for a full evaluation should precede any invasive procedure. Such referrals are clearly not necessary for all chronic pain patients. For some, pharmacologic management alone can provide adequate relief. Antidepressant medications. The tricyclic antidepressants, TCAs, particularly nortriptyline and dicypramine, Table 18.1, are useful for the management of chronic pain. Although developed for the treatment of depression, the tricyclic antidepressants have a spectrum of dose-related biologic activities that include analgesia in a variety of chronic clinical conditions. Although the mechanism is unknown, the analgesic effect of tricyclic antidepressants has a more rapid onset and occurs at a lower dose than is typically required for the treatment of depression. Furthermore, patients with chronic pain who are not depressed obtain pain relief with antidepressants. There is evidence that tricyclic antidepressants potentiate opioid analgesia, so they may be useful adjuncts for the treatment of severe persistent pain such as occurs with malignant tumors. Table 18.2 lists some of the painful conditions that respond to tricyclic antidepressants. Tricyclic antidepressants are of particular value in the management of neuropathic pain such as occurs in diabetic neuropathy and post-herpetic neuralgia, for which there are few other therapeutic options. The tricyclic antidepressants that have been shown to relieve pain have significant side effects. Table 18.1, Chap. 466. Some of these side effects, such as orthostatic hypotension, drowsiness, cardiac conduction delay, memory impairment, constipation, and urinary retention, are particularly problematic in elderly patients, and several are additive to the side effects of opioid analgesics. The selective serotonin reuptake inhibitors such as fluoxetine, Prozac, have fewer and less serious side effects than tricyclic antidepressants, but they are much less effective for relieving pain. It is of interest that venlafaxine, Efxa, and duloxetine, Cymbalta, which are non-tricyclic antidepressants that block both serotonin and norepinephrine reuptake, appear to retain most of the pain-relieving effect of tricyclic antidepressants with a side effect profile more like that of the selective serotonin reuptake inhibitors. These drugs may be particularly useful in patients who cannot tolerate the side effects of tricyclic antidepressants. Anticonvulsants and antiarrhythmics. These drugs are useful primarily for patients with neuropathic pain. Phenytoin, Dilantin, and carbamazepine, Tegretol, were first shown to relieve the pain of trigeminal neuralgia. This pain has a characteristic brief, shooting, electric shock-like quality. In fact, anticonvulsants seem to be particularly helpful for pains that have such a lancinating quality. Newer anticonvulsants, gabapentin, Neurontin, and pregabalin, Lyrica, are effective for a broad range of neuropathic pains. Furthermore, because of their favorable side effect profile, these newer anticonvulsants are often used as first-line agents. Chronic opioid medication. The long-term use of opioids is accepted for patients with pain due to malignant disease. Although opioid use for chronic pain of non-malignant origin is controversial, it is clear that, for many patients, opioids are the only option that produces meaningful pain relief. This is understandable because opioids are the most potent and have the broadest range of efficacy of any analgesic medications. Although addiction is rare in patients who first use opioids for pain relief, some degree of tolerance and physical dependence is likely with long-term use. Furthermore, animal studies suggest that long-term opioid therapy may worsen pain in some individuals. Therefore, before embarking on opioid therapy, other options should be explored, and the limitations and risks of opioids should be explained to the patient. It is also important to point out that some opioid analgesic medications have mixed agonist-antagonist properties, for example, dorphenol and buprenorphine. From a practical standpoint, this means that they may worsen pain by inducing an abstinence syndrome in patients who are physically dependent on other opioid analgesics. With long-term outpatient use of orally administered opioids, it is desirable to use long-acting compounds such as levorphenol, methadone, sustained-release morphine, or transdermal fentanyl, Table 18.1. The pharmacokinetic profiles of these drug preparations enable the maintenance of sustained analgesic blood levels, potentially minimizing side effects such as sedation that are associated with high peak plasma levels, and reducing the likelihood of rebound pain associated with a rapid fall in plasma opioid concentration. Although long-acting opioid preparations may provide superior pain relief in patients with a continuous pattern of ongoing pain, others suffer from intermittent severe episodic pain and experience superior pain control and fewer side effects with the periodic use of short-acting opioid analgesics. Constipation is a virtually universal side effect of opioid use and should be treated expectantly. As noted above in the discussion of acute pain treatment, a recent advance for patients is the development of peripherally acting opioid antagonists that can reverse the constipation associated with opioid use without interfering with analgesia. Soon after the introduction of a controlled-release oxycodone formulation, OxyContin, in the late 1990s, a dramatic rise in emergency department visits and deaths associated with oxycodone ingestion appeared, focusing public attention on misuse of prescription pain medications. The magnitude of prescription opioid abuse has grown over the last decade, leading the Centers for Disease Control and Prevention to classify prescription opioid analgesic abuse as an epidemic. This appears to be due in large part to individuals using a prescription drug non-medically, most often an opioid analgesic. Drug-induced deaths have rapidly risen and are now the second leading cause of death in Americans, just behind motor vehicle fatalities. In 2011, the Office of National Drug Control Policy established a multifaceted approach to address prescription drug abuse, including prescription drug monitoring programs that allow practitioners to determine if patients are receiving prescriptions from multiple providers and use of law enforcement to eliminate improper prescribing practices. This increased scrutiny leaves many practitioners hesitant to prescribe opioid analgesics, other than for brief periods to control pain associated with illness or injury. For now, the choice to begin chronic opioid therapy for a given patient is left to the individual practitioner. Pragmatic guidelines for properly selecting and monitoring patients receiving chronic opioid therapy are shown in Table 18.3. Treatment of neuropathic pain. It is important to individualize treatment for patients with neuropathic pain. Several general principles should guide therapy. The first is to move quickly to provide relief, and the second is to minimize drug side effects. For example, in patients with post-herpetic neuralgia and significant cutaneous hypersensitivity, topical lidocaine, lidoderm patches, can provide immediate relief without side effects. Anticonvulsants, gabapentin or pregabalin, see above, or antidepressants, nortriptyline, disopramine, duloxetine, or venlafaxine, can be used as first-line drugs for patients with neuropathic pain. Systemically administered antiarrhythmic drugs such as lidocaine and mexiletine are less likely to be effective, although intravenous infusion of lidocaine can provide analgesia for patients with different types of neuropathic pain. The relief is usually transient, typically lasting just hours after the cessation of the infusion. The oral lidocaine conjugal mexiletine is poorly tolerated, producing frequent gastrointestinal adverse effects. There is no consensus on which class of drug should be used as a first-line treatment for any chronically painful condition. However, because relatively high doses of anticonvulsants are required for pain relief, sedation is very common. Sedation is also a problem with tricyclic antidepressants but is much less of a problem with serotonin, norepinephrine reuptake inhibitors, SNRIs, for example, venlafaxine and duloxetine. Thus, in the elderly or in patients whose daily activities require high-level mental activity, these drugs should be considered the first line. In contrast, opioid medications should be used as a second or third-line drug class. Although highly effective for many painful conditions, opioids are sedating, and their effect tends to lessen over time, leading to dose escalation and, occasionally, a worsening of pain due to physical dependence. Drugs of different classes can be used in combination to optimize pain control. It is worth emphasizing that many patients, especially those with chronic pain, seek medical attention primarily because they are suffering and because only physicians can provide the medications required for pain relief. A primary responsibility of all physicians is to minimize the physical and emotional discomfort of their patients. Familiarity with pain mechanisms and analgesic medications is an important step toward accomplishing this aim.